Basically, as you know, CAR T cell therapy has reshaped the landscape of B-cell lymphoma treatment. However, relapse after CAR T cell, particularly in the case of diffuse large B-cell lymphoma, remains an unmet medical need. So when we look, for example, to the Zuma-1 study for advanced DLBCL, their progression-free survival at 5 years is only 32%, which means 8% of patients treated with CAR T will have. Still, around half of the patients are not cured with this treatment modality based on Transform and Zuma-7 studies. And so the first question is, can we predict CAR T cell therapy failure? And indeed, we have prognostic factors that predict outcome of CAR T cell therapy. Some of them are patient-related, such as the age, performance status, and comorbidity index, but these we cannot do anything about. Others are lymphoma-related. For example, some histologies will do better or less well after CAR T. Primary mediastinal B-cell lymphoma typically will do better. The total metabolic tumor volume, the bigger it is, the less good are the results. And the LDH level also can predict outcome. And similarly, even the number of extranodal sites can predict the risk of disease progression after CAR T. We also have the clinical impact of CD19 expression, with higher CD19 expression correlating with better response rates and event-free survival. And the number of prior lines of therapy will affect directly the quality of the resulting CAR T cell product. And finally, previous exposure to bendamustine, particularly recent exposure, less than 9 months typically, will lead to a lower quality of the CAR T cell product and therefore a higher risk of progression after CAR T. So yes, we can predict a CAR T failure, but what is the prognosis after CAR T failure? Is CAR T cell therapy failure a death sentence? So in general, when we look to multiple published series and studies, we have in general a dismal prognosis with a median overall survival after failing, for example, axi-cel of approximately 6 months. But not all patients will have this dismal outcome after CAR T cell failure. And we have prognostic scoring systems, including performance status, LDH, hemoglobin, number of extranodal sites, and months from CAR T to progressive disease that will predict the outcome. For example, patient with low risk will have a 1-year survival above 56%. And again, the time to treatment failure is a key prognostic factor. So to come back to your question, what are the treatment options post-CAR T cell therapy failure? So we have multiple available therapies. And when we look to meta-analysis about the pooled complete remission rates, with bispecific antibodies, we have 33% CR rate, with Polatuzumab-based 29%, radiation therapy-based 25%, but these are not the same patient. And then we have other option, checkpoint inhibitor 22%, TAFA or LONCA-based 17%, and chemoimmunotherapy 7%. By definition, these patients are chemorefractory. So bispecific antibodies, whether we look to glofitamab, epcoritamab, or odronextamab, they have a similar efficacy after CAR T-cell therapy compared to patients who receive these bispecific without prior CAR T-cell therapy, and the efficacy is dependent on the time to relapse after CAR T. So the earlier the relapse after CAR T, the lower the efficacy. And this is related somehow to T-cell exhaustion and lack of immune recovery that can explain the lower outcome, the inferior outcome after early CAR T-cell therapy failure. So we have some specific trials with bispecific antibodies after CAR T-cell therapy, and overall we have a complete remission rate of around 30 to 45% and a 1-year progression-free survival of 27 to 37%. And when we look to the meta-analysis of the use of bispecific antibodies after CAR T-cell therapy failure, we have a pooled PFS of 31%, overall survival 41%, relapse rate 43%, and treatment-related mortality of 17%. So what about allogeneic transplants? Well, allogeneic transplant represent a potentially curative treatment modality and probably the only one for patients who have failed CAR T-cell therapy. And we have recent results published in 2022 and 2024 showing a 1-year survival exceeding 60 to sometimes 80% after CAR T-cell therapy. And this survival is directly dependent on the disease status at transplant, with patients allografted in complete remission having a significantly better outcome. And when we look to the meta-analysis about the pooled PFS rate, it's around 43% after allotransplant, overall survival 59%, treatment-related mortality 20%, and we have a plateau, again indicating that allotransplant after CAR T-cell failure can be curative. So in conclusion of what I presented at the EBMT meeting in Madrid, is that clinical models are helping in better predicting outcomes of patients with relapse progression after CAR T-cell therapy, and patients with low risk score can still have long or longer life expectancy. In allotransplant eligible patient, achievement of a complete remission prior to the procedure is necessary to achieve higher PFS and overall survival. Clinical trials remain the best option whenever available and possible. And in the absence of clinical trial, bispecific antibodies and Polatuzumab-based regimen appear to yield the highest complete remission rate. Radiation in localized relapse will give you around 25% complete remission rate.